Thank all of you all who are watching these video series. We appreciate it, and we've had a lot of fun doing them. So we're going to start something a little bit different tonight. We've been looking at the scapula, investigating it, learning it, discussing it for many years. Recently, Dr. Tim Uhl conceived and developed an idea of a couple of seminars to kind of codify and kind of put together all this information. We thought the best way to make this available is through a roundtable. And so we have the first roundtable here is going to look at the most common questions that we get asked all the time when we go and give talks. We feel that this is going to be the best way to kind of set the basis for what we want to look at, to identify some of the major issues that exist, get some of the basic concepts going, and to kind of give an idea of where we want to go with the more in-depth evaluation and talks in further sessions of these videos. So our panel is Dr. Tim Uhl, Dr. Aaron Shasha, Dr. Austin Stone, Dr. Jeff Grantham. They all have a lot of experience and expertise in this area. So let's go ahead and get started with some questions. The first question has really got to be, what are the roles of the scapula? Why do we even worry about this bone? What's going on with the scapula in shoulder and arm function? Really, what does this bone do? So I'm going to ask Dr. Shasha and Dr. Grantham to kind of give us some context about what the roles of the scapula are. So, Aaron?
First and foremost, when we're talking about the scapula, you think of the body in terms of the kinetic chain and how it is the transfer point between the large muscles of the trunk, pulling all that energy up towards the arm and allowing that to happen. And so honestly, the arm doesn't function unless that piece of bone is there and optimizing effectively. And that actually leads into other aspects. It leads into concavity compression, and it leads into essentially serving as this base of control for the rotator cuff. And so really, it's just this important piece of the puzzle that we can't overlook because of its intricate relationship to the shoulder.
One of the major problems is that it's an underappreciated, I think, part of this puzzle. So, Jeff, what do you think?
Yeah, no, the way I like to think of this shoulder blade is it's the base of this long crane. The arm is a long lever arm, and its attachment to the body is through the shoulder blade. So if the shoulder blade is not working effectively, if you don't have a stable base there, anything distal to that can't work effectively. And we often see a lot of pathology based upon that.
Yeah, so Tim, Aaron, Austin, anything else?
I think you guys are exactly right. I think one thing from a biomechanical standpoint, when you look at a lot of the biomechanical studies, they're really showing humeral thoracic motion. They often don't capture the scapula, all the baseball studies, all the throwing studies, so it's sort of the missing link, if you will, in the segment that's sort of not completely appreciated.
Yeah. Austin, anything?
Well, and I think another really important part about the scapula that's often underappreciated, certainly in our medical education coming up, was the importance of positioning the glenohumeral joint such that the arm can do what it needs to do. And I think that's just really something that's critically overlooked that is going to be very foundational for tonight.
Yeah, I think basically we're talking about scapulohumeral rhythm as kind of the basis for transfer forces, stability of the rotator cuff, stability of the glenohumeral joint. We didn't mention the fact that there's impingement, external, internal impingement based on altering positions of the scapula. And I think we're going to look at this in maybe two populations. One is what I would call the workers, the heavy duty, the need for a lot of stability and strength and putting their arm in positions. And then what I call the dynamics, the ones that have to do a lot of overhead quick motions. What do you think about it? Is there an overlap? What do you think? Is there just separate groups? How do you think about the roles of the scapula in those two maybe separate populations? Jeff?
I think they're similar and they're different. One's more of a stabilization, one's more of a dynamic motion through a full range. So like looking at baseball players, overhead athletes, it's part of that kinetic chain. It needs to work in continuity with the lower body, the trunk, the arm rotation, and it needs to be in sync with those. Once they get out of sync, we start thinking about impingement and other pathology that can come from it. The big thing is getting it in rhythm, being strong with it, so you can get the forces downstream, so you can get the acceleration as well as the deceleration. You can slow down the arm after you throw or spike a volleyball. And so the intricacies of that movement can really change efficiency as well as injury.
Yeah. Aaron, what about the workers or the people kind of walk around and the ones that kind of sit in a desk all day long or have to lift out in front or overhead? Those are motion problems that you see quite frequently.
And they are, and Dr. Grantham said it very well, is that the overlap exists where essentially you're still using the chain. You're just using it more in a confined space. Mm-hmm. And I think that's really where the distinction lies, is that you have this much shorter window of functionality, if you will, in a set position more often than not, with some very few exceptions, right? So until the day that the construction worker starts throwing his hammers across the yard, then we can call him an athlete in that regard. But right, as of right now, I mean, we work in this very tight window. And even those that work overhead still do that in that confined space when we're talking about mechanics or what have you with people who reach above shoulder level.
So anybody can have this problem. If you got a shoulder and arm problem, no matter what your occupation or function, then you have a capability because the body works that way to have an alteration that can cause some problems. Anything else? Any other questions? Thoughts on this question here?
I think that's a fundamental concept to appreciate: proximal control for distal mobility.
That's exactly right. So therefore, you got this proximal control of the scapula on the trunk and on the kinetic chain to allow the position and the motion that's going to be efficient. Okay, well, so let's move on. So the second question we always get, okay, you told me what the roles are. Now let's talk about how does the body allow the motions and positions of the scapula so that it works. And we know that mainly this is controlled by muscles. So the periscapular muscles are key points in this. So how do these periscapular muscles function to optimize these scapular roles? So ask Dr. Uhl and Dr. Stone to kind of weigh in there. So Austin, how do the muscles work there?
Well, I think that one of the challenging things when you're approaching the scapula is you hear the words like trapezius and levator scapulae and rhomboids. You remember them from medical school anatomy classes, but it's far more than that in their attachments. In the dynamic portions of the muscle really are what control the scapula. And I think that's something that's very challenging, certainly for me to grasp and understand, but when you're approaching can be very intimidating. And so, if you think about just very simply like the scapular elevation, the shrug, you're involving the trapezius there, upper portion of that trapezius muscle, the levator scapulae, and the rhomboids. But then the motion starts to really evolve and get more complicated when you're talking about protraction and retraction, and you're starting to involve a lot more muscles in there. And so if we're thinking about scapular protraction, you're getting pectoralis minor, and the serratus anterior is coming into play, and pec major as well. And so if you think about protracting the pectoralis major and minor, will downwardly and internally rotate that scapula with anterior tilt. And you often see that posture a lot in people like you were referencing earlier, right? It's everybody comes in there and their shoulder hurts, and you know why. But if you'd like to comment on retraction and the opposite there.
Yeah, well, I think one of the problems in teaching anatomy is we teach it by sections and prime movers. We don't talk about a system. And it's a synergistic system that really has to work together. I can't tell you how many times I'm teaching my students over and over again. The supraspinatus works beyond the first 10% of abduction. Whoever said that just wears me out. But I think with retraction, to elevate your arm, if you don't have that stable base and get that initial control of the scapula stabilizers. And when we look at EMG, and I've done a lot of EMG research, we see early activation of the upper trap and serratus throughout the range of motion. But the lower trap really doesn't turn on excessively until you get up around 90 degrees of arm elevation. So appreciating that coordination you were talking about with throwing or just lifting your arm up to put a tool away or to throw a hammer, you need to appreciate that. And with pathology, that really starts to change. We see inhibition. We know that pain shuts down those muscles. So being able to turn on your lower trap and activate those muscles at the right time in the sequence is really critical. And I think people say, okay, I'm going to do an external rotation exercise. I'm going to strengthen the rotator cuff. Well, you can't strengthen the rotator cuff unless the scapula is stable. And I think that is not always appreciated when we're giving instructions and moving those activities.
It's a sequencing, coordination of activation sequencing, and it's very funny. You talk about serratus anterior. Like you said, if you go prime mover, serratus anterior is this, but where does the serratus work for our throwers, for sure, is back here. And so you have to understand some of those concepts as well. And the individual muscles, I get your comment. What do you think about trying to look at individual muscles around the periscapular area? Aaron, what?
The reality of it is we can't do that clinically. I mean, we cannot partition out and specifically say, I'm only going to look at X. It just doesn't work that way. The body's not designed that way. But I do think what it does is come back to, at least as far as updating your thinking, is going back to actually what's more of a foundational concept, which is architecture and understanding where fibers run in which direction and orientation. Because when we're talking about the serratus is a perfect example of that. It's such an expansive muscle. But you have diagonal fibers going up, you have actually diagonal fibers going down. And so as a result, that's why it's such a big player in all of the kinematics we talk about, for all the way from not just upward rotation and where it works really well in elevated positions, but also for posterior tilt, as well as for that external rotation that we're talking about.
So, Jeff, we're talking about the periscapular muscles, but if you look at the EMG work of the sequencing, you see that your contralateral hip muscles activate before the periscapular muscles activate, and the distal muscles will only work as well as they are facilitated by the periscapular muscles. So you can't think even not only individual periscapular muscles, but periscapular muscles as a group without thinking above and below. So how do you feel about that? How do you look at that, or how do you put that into your thought process?
Yeah, and that goes back to the kinetic chain, right? And so nothing can work distally if we're not strong proximally. And so that energy is a transfer from proximal to distal. And so with that hip stability, now I can activate those periscapular muscles. Without that hip stability, I have a hard time getting back and being strong and stable with my scapula. And so, yeah, when evaluating, you have to start from the ground up. You really got to see those hip muscles working effectively. And you can, oftentimes, we'll talk later, but we can evaluate and show that by activating those glute muscles, we can get better scapula stabilization pretty quickly, pretty easily, just in the clinic setting.
Mm-hmm. One quick question here. So we've talked about how every muscle is important. They all work together. I would make the claim that my favorite muscle around the periscapular area is the serratus, because I think the serratus by itself, if you don't have the serratus, then your scapula really doesn't work very well. I would like to ask your all's opinion about that.
Yeah, it's a critical muscle. It's a very big muscle. I guess because my name is Tim L. Uhl, I'm a lower trap kind of guy, but I think I spent a lot of time working on the lower trap, but I think what happens is we always worked on getting retraction first to get that stable base. And to 80, 90 degrees, you're good. You can function that way. But if you can't allow that to upwardly rotate, which is really where we find serratus anterior function at 120, 130. I know the classic manual muscle test was a forward punch, but it's really interesting. Manual muscle testing was for polio patients, and it wasn't really for musculoskeletal or workers or those components. And as we're finding more and more research, EMG manual muscle testing isn't isolating one. It might bias one muscle group, but it doesn't isolate a muscle. Maybe with the flexor digitorum profundus, we can isolate. But I guess I've always focused first on the lower trap, but I think over probably the last 4 or 5 years, I've started to appreciate the serratus role more and more with dysfunction.
Yeah, if you take a worst case scenario, paralysis of the long thoracic nerve and serratus anterior palsy is the most limiting muscle deficit that you can have for the shoulder. You cannot raise your arm above 90 degrees. Every other muscle in your body is normal, and you cannot raise your arm above 90 degrees when the serratus is not working. So I think, to me, that kind of shows the point that you're making right there. Any other points about, so muscles are important. Muscles are somewhat difficult. We're going to talk a little bit about how you evaluate them, but muscles are just plain tough, but you do have to know those muscles. And we'll get into a minute about when you see this scapular problem, what muscles seem to be playing that role. So let's go on. So we talked a little bit about scapular function and dysfunction. Now we get down to the next question here, okay? What is scapular dyskinesis? Now, I'm going to say that it's not scapular dyskinesia. So I want to know what scapular dyskinesis is. How do you define it as it relates to scapular and arm dysfunction? So I'm going to ask Dr. Shasha and Dr. Stone to kind of weigh in on that. So Aaron, what is scapular dyskinesis?
So it's actually quite easy. I mean, in the term in and of itself, it's alteration of motion. And so obviously we have some depiction or some illustration of what we believe is normal. And so when we start to deviate from that, that's when we start getting into true dyskinesis. But, to boil this down to even more specifics, it turns into landmarks and what we see and when we see them, right? So when we see prominence of the medial border or the inferior angle when we're not supposed to, or more so than when we believe we should. When we start to see, when a person elevates their arm and they shrug earlier than they should, we would call that dyskinetic. And also when the arm is brought down back from the ascended position down to a descended position, we start to see the scapula come off the thorax more so than it's supposed to. So in all of those situations, we're talking about abnormal motion.
Awesome.
Yeah, I think the importance of dyskinesis and scapular dyskinesis is it associated with symptoms, right? Does this cause a problem? And so generally, if they're in your office, it's causing a problem, but perhaps maybe not in the training room, right? You can be a very effective athlete and still have some scapular dyskinesis. But if they're in your office, you have to begin to tease that out. And I know we'll talk about that shortly, but the first thing that I look for is there that medial prominence, that resting position of the scapula, that inferior medial border, is that prominent? And if not, then we start some of those dynamic evaluations to see if it's behaving abnormally through the motion arc. And so, I think that that if you have altered protraction, you're going to end up with loss of motion, and that's kind of a dead giveaway when you start to evaluate it. But I'd just circle back to say it's got to be correlated with some sort of symptom. No pain, no problem.
Yeah. So Tim, I know back in 2013 we came up with a definition. We wrote it up. So what's your operational definition of scapular dyskinesis?
So I think it's both a resting position appearance and then a movement abnormality. I think it's important that we do talk about this as an impairment, not a diagnosis. So just like I can lose hip internal rotation with an arthritic hip, I can have abnormal scapular movement. I can still function, but maybe not at the level I want to function at or at the performance level. So my operational definition, I agree with Dr. Stone that it's probably not a problem unless they're complaining about it. When you look at 45 people in class, everybody can find little minor abnormalities, but they have no pain, they have no symptoms. That's not what we're talking about. Yeah. So seeing an abnormal looking scapula with no dysfunction, no pain is not what I would consider scapular dyskinesis. The one other thing I would say, and it's important for clinicians who are starting to look at that, don't be fooled by the spine, because the spine can give you scoliosis or a rib hump, and it can be an underlying, or God forbid, something worse, right? A more sinister tumor or something like that. So it's still important to look at, but there are other causes other than the typical things we've treated for the last odd number.
Yeah. So I always say that dys, meaning alteration of, kinesis, motion, is the kind of what we look at is the root word for this. Dyskinesia, Aaron, what's a dyskinesia?
So by definition, it's a loss of what was once voluntary. So basically, voluntary becomes involuntary. And so what we know about scapular kinematics is that if you think of it in terms of what we call joint play, they're accessory motions. And so you don't control them from the start. So how can you lose something you already couldn't control? Right? And so therefore, the term in and of itself of dyskinesia is not correct.
Dyskinesia is also is a neurologically based alteration of motion, for example. And so I think dyskinesia can be a part of a dyskinesis, but the dyskinesis is the broader term that encompasses most of these alterations of motion and position that we see. For example, the definition we had in the book was that it's an alteration of position of the scapula characterized by either a resting position of inferior medial prominence, medial border prominence, and then on motion that you see a worsening of that prominence one way or the other, but also that on the way back down you see this automatic kind of flip that will be very prominent that you can see. So what it is, it's an alteration of motion. That's all there is to it. Now, how that then fits in with these roles that we've been talking about and how these muscle problems may exist then puts it into this whether we treat it or not. It's not a diagnosis. It's not a cause and effect. And it's not a pathology necessarily by itself. So, but it is something that is there that we need to evaluate.
What I find very interesting is how many patients have bad scapular dyskinesis but don't realize it. Nobody ever looks at your back. Your eyes are on your front. You don't see your back, and so you can find out a lot of information by just evaluating it, but you have to actually look for it.
Mm-hmm. That's right. Because our study was 70% of the patients had some kind of scapular dyskinesis.
Yeah, so when we came up with the original classification systems, we had 4 categories. 3 of them were pathological, 1 was normal. And it was really interesting that even in the people that we categorized as normal had some minor alterations. So we subdivided our group where both of us agreed that there was no dyskinesis. So those were sort of our normals. And so they created our confidence intervals of what we would say is atypical or abnormal scapular motion, because nobody had really tried to classify what is normal scapular motion versus what is abnormal. So we had to come up with some kind of baseline. So that was how we agreed to write that up. But it was interesting that even when you had people with no pathology, not the people that we based the norm on, there was still some difference in one direction. And probably one of the limitations of that study is we tried to fit people into one of 4 categories, and really 76% of the time they had pathology, or not pathology, but abnormal movement with no symptoms in at least 2 planes. So it's not a simple put it in a box and there it goes. There's no absolute one type of pattern. Yeah. Like you were saying, medial border's a little higher or more prominent, but often it's multiple.
All right, so the next question is, all right, so we say that there's a scapular dyskinesis. There's got to be, and it's not a diagnosis, then what are the causative factors that may create this alteration of motion or position? We, like I say, try to break them down into maybe 2 broad categories: alterations of anatomy, called pathoanatomy, or alterations in the physiology, these muscles, we call them pathophysiological. So, Dr. Uhl, Dr. Grantham, tell me what are the causes of this problem?
So as a surgeon, I like pathoanatomy.
Of course you do.
Absolutely. So you see the extreme forms, and that's where we talk about scapular winging, right? You have loss of innervation to one of the muscles, so you're going to have a very severe scapular dyskinesis, creating usually significant functional loss. Another direct and anatomical problem to the shoulder blade is a big traction injury where you can actually get some detachment of the rhomboids or the lower trapezius, and therefore you can't get that inferior medial border stabilization. Downstream, there's some non-direct, some kind of other causes of scapular dyskinesis because you're compensating for something. So everybody's seen the rotator cuff patient with kind of pseudoparalysis, a hard time activating and elevating their arm. That's kind of hitching it up, right? They're kind of using that shoulder blade to throw that arm up. That's another form of scapular dyskinesis. There's
Are we through? Are you? Keep on, sorry.
yeah. So there's labral pain, internal impingement can certainly cause you to want to alter where your glenoid position is, so you stay away from that pain generator. So there's many anatomical problems around the shoulder blade or around the actual glenohumeral joint that can create scapular dyskinesis. And those are the patients that oftentimes physical therapy is not going to get them better, but that's where a surgical fix is helpful to get them past that scapular dyskinesis that we see in clinic, but we need to fix the anatomy to allow their periscapular muscles to work appropriately.
Yeah, no, I totally agree. And so because I'm a physical therapist and an athletic trainer, I don't get to cut on people. And so we're trying to come at it from what our expertise is. Where's the mobility impairments? Where's the strength or motor control deficits? And so I think it's a good relationship between the rehab clinician and the orthopedic surgeon, that level one, let's see what we can do. Even if there is a little small rotator cuff tear, can we get them functional again and teach them how to start moving again? So typically we start with mobility. So the classic tightness of pec minors, lats, posterior shoulder is a real common scenario that we see, not just in throwing athletes, but in the regular working worker, or even somebody who is working at a computer all day. So in my experience, once I start to get some mobility, then I can start to work on motor control, not strength, but motor control, that sequencing of turning on the muscles. One of the things that we did a long time ago is people, I don't know why it is, but when we evaluate a shoulder, everybody wants to straighten their arm all the way out and lift their arm up, and that's how we evaluate a shoulder. Well, in function, we take our glass and we put it up on the shelf with an elbow bent. So what our brain is doing is offloading the weight of the arm. So offloading the weight of the arm with a closed chain or a movable boundary allows us to teach them how to move without that shruggy compensation. There is muscle weakness, or really muscle endurance. These are more tonic type muscles, so this endurance component. I think one of the issues is if we do have a bad trauma, a shoulder dislocation or a fracture, and they've got to heal, we as physical therapists and athletic trainers and others need to focus on, okay, great time, it's immobilized, let's work on spine mobility, let's work on cervical mobility, let's work on pelvis control, let's work on the hips, and try to get some of that proximal stability or mobility reestablished. And that, as you were saying earlier, being able to activate those proximal muscles sets up the lower trap and serratus and those muscles to work better when we get them going again. But that's a pretty comprehensive list of things to consider. And so it takes a little while to get past, oh, I found a rotator cuff tear, let me give them an exercise, to thinking all of those components. So I think simply keeping it, are they stiff? Do they have mobility issues? Is this a pathoanatomical trauma? I can't fix fractures. That's your all's jobs. But more often than not, people present with subtle irritations and let things sort of control. And then if we can't get the rotator cuff tear well, then thank goodness for good orthopedic surgeons. We'll send them your way.
That's right. So there's these two types of causative factors. They interplay. I mean, they're not just, if you got a labral injury, that's the only thing you got. No, you got a labral injury that's inhibiting the muscles, the labral injury may have occurred because you have this pec minor tightness and this protraction. So you got to always have the interplay between these two. But sometimes you've got to look at this whole, as you say, the whole complex when they come in there, and we can kind of break them down into easy ways of that. But they still, and even if they have a labral injury and scapular dyskinesis, you fix the labrum, it doesn't mean the scapula gets better all by itself. You have to go right back and do that again. Okay, Aaron, anything else before we go on?
Now, I think the real highlight here, is, talking about this in particular, is we have to really wrap our heads around this impairment concept, right? It is by definition, it's any loss of physical or even mental ability, right? And so as a result, we are finding the cause, right? And those causative factors really is where people need to camp from a clinical standpoint to really figure out what's driving this.
So I always like to talk about victims and culprits. You got a victim out here somewhere, and the culprits are lurking in the bushes, and we got to find them. And very rarely is culprit a single thing. It's culprits that we have to kind of look at. And the question is about kind of the basics here. So we've covered the basics of the scapula, a bit of scapular function, dysfunction, scapular dyskinesis. So we want to thank you all for watching this. And we're going to have the second part now, which is going to be a little bit more clinical application. That'll be in the next video series.